Video. Thank
Hi
you.
there, my name is Catherine Talcott, and I want to thank the organizers for the opportunity to speak at this virtual conference. I'll be speaking about some work that I've done with my colleagues at Cole Eye Institute, including my mentor, Dr. Justice Ehlers, on intraoperative OCT and three-dimensional viewing systems. Some of the funding related to this project came from an ISC with Alcon. Although there has been significant advances in vitreoretinal surgery over the past decade, including with the advent of smaller gauge instrumentation and increasing the cutter weight, visualization with a standard operating microscope has been relatively stagnant in its evolution. Three-dimensional heads-up display offers a step forward. It provides a digital stereoscopic view of the surgical field on a high-definition monitor. It helps free the surgeon from the confines of microscope eyepieces and may offer benefits in terms of ergonomics and efficiency. When I was a fellow at Wills, we looked at comparing three-dimensional heads-up display to a standard operating microscope for macular surgery. This was a prospective, unmasked, randomized clinical trial looking at 39 patients who were having macular surgery for either an epiretinal membrane or a macular hole. We found that the 3D heads-up display required less endoillumination, but ease of use and the peel time was still significantly better with the standard operating microscope. This points to potential benefits of the 3D heads-up display, but also showcases that there are still some limitations. Another innovation in terms of surgical visualization is that of intraoperative OCT. It can provide a valuable surgical adjuvant to ophthalmic surgery, which can increase our understanding of the pathophysiology of surgical diseases, as well as to provide real-time feedback to the surgeon. Here are some examples that can help to look at the utility of this technology. In this instance of a patient undergoing a macular peel for an epiretinal membrane, real-time OCT imaging can show the traction that's exerted on the retina with peeling of the epiretinal membrane and can help to give feedback to the surgeon. Another helpful example is subretinal TPA for submacular hemorrhage. Here you can see that the subretinal placement of the cannula is confirmed, making sure that it is indeed subretinal and not sub-RPE prior to the TPA being injected. Another instance that it can be helpful is actually looking outside of the eye in terms of the creation of scleral windows for a uveal effusion syndrome. Real-time OCT can show the exact tissue depth during the creation of the windows, as well as to also confirm that a sclerotomy was also made. Overall, intraoperative OCT can provide surgeons with additional information on subtle changes in the retina in response to movements being made during surgery. This can help to guide procedures when necessary, but also be able to tell surgeons when the goals of the surgery has been achieved. So intraoperative OCT can help lead to a safe and more efficient surgery with improved outcomes. Although these two technologies and innovations have been looked at separately, we were wondering if we could combine them together. For this project, we looked at a comparative assessment of conventionally microscope integrated to digitally enabled intraoperative OCT in the DISCOVER study. Previous studies have supported the feasibility and usefulness of intraoperative OCT, including the DISCOVER study, which is a prospective study that showed a strong surgeon preference for visualizing the OCT data on a 2D screen that required looking away from the surgical field compared to using OCT data that's injected into the microscope oculars. This might in part be due to the limited visualization of the OCT when it's injected into the microscope oculars, as well as the fact that those images need to be transparent. So what this highlighted for us was the need for a new integrative digital surgical theater. We have previously published work on integrating intraoperative OCT into a three-dimensional heads-up display to really engage with an integrative theater. So the purpose of our project was to compare surgeon experience between conventional microscope integrated intraoperative OCT and digitally enabled intraoperative OCT with a 3D visualization system in the DISCOVER study. This was a sub-analysis of that study comparing conventional intraoperative OCT to digitally enabled intraoperative OCT. The IOCT data stream could be reviewed by surgical field-based visualization or non-surgical based field visualization. And we sought to compare what the perceived utility of intraoperative OCT was, as well as surgical field visualization and efficiency, as well as ergonomics feedback. In order to do this, standardized questionnaires were completed following surgery. Overall, The baseline characteristics were very similar in between our two groups of the conventional intraoperative OCT and digitally enabled intraoperative OCT, with the most common indication for surgery being that of epiretinal membrane in both groups. There were no intraoperative surgical complications that were attributed to intraoperative OCT, and the rate of postoperative complications was very similar in between the two groups. We found that 3% of surgeons in the conventional intraoperative OCT group used surgical field-based visualization compared to 68% in the digitally enabled intraoperative OCT group. Both groups found that there was valuable information added by intraoperative OCT in relatively similar amounts, and that was in about 50% of cases. Part of the reason that surgeons, in terms of surgical field-based visualization of intraoperative OCT, might be a preference is based on the layout in the OR. As you can see on the left, when the surgeon and the assistant are using surgical field-based visualization, they can look ahead to the screen that they've already been watching the surgery on to be able to get more information about the intraoperative OCT. Rather, screen-based visualization requires both the surgeon and the assistant to look away from the microscope in an ergonomically unfriendly position to be able to look at those smaller images on the screen. And accordingly, we found that this probably manifested itself in terms of our ergonomic findings. We found that there were significant higher amounts of back discomfort and headache in the conventional intraoperative OCT group. The intraoperative OCT experience was very similar in between the two groups, with the exception of the viewing or the rating of the macular view, which was found to be significantly higher, with surgeons finding this view excellent in the digitally enabled group as compared to the conventional intraoperative OCT group. There are some limitations with this study based on, first of all, the person filling out the survey. So the surgeon was the one to fill out the survey in these in the study, although they, in some cases, might have been sitting at the scope versus the side scope. And that, I think, could affect their experience during the case. Also, there was a lack of randomization in this study. Surgeons needed to include cases in both groups in order to be enrolled in the study, but they were not randomized. So what's next? I think really the next thing that's going to help change the integration of these two technology is really improving the quality of the intraoperative OCT images that are placed in the surgical field, as well as to be able to integrate parameters from the surgical machines, including such as a Constellation, into the screen to really give that immersive surgical experience. Another example that can show what this digitally enabled intraoperative experience can be like is by looking at more complicated cases such as this, including attractional retinal detachment, where you can actually move the intraoperative OCT pictures to be able to get a better sense of membranes that can really help to guide the movements that we're making to decide when the goals have been achieved of the surgery. And also the integration of the parameters from your Constellation in this case can be very helpful to guide our surgical movements and well as to give real-time feedback to the surgeon. Although we have primarily in this talk really looked at Ngenuity as one viewing system, there's more viewing systems that are also coming down the pipeline, which are exciting. One of these is the Artivo system made by Zeiss, which is purported to be the first 3D capable digital ophthalmic microscope, which offers a hybrid mode to allow the surgeon to view the surgical field using 3D imaging on the screen or through the oculars. These images are viewed on a 55-inch 4K resolution screen that comes equipped with intraoperative OCT. I'm not sure if anyone in the audience has had an opportunity to use this system, but we've started trialing it at Cole and are actually working on a study to compare this to a conventional microscope. And there may be improvements in latency, surgical field color, needing less endoillumination, as well as increased ease of utilizing the intraoperative OCT. So it'll be interesting to explore this technology further. In conclusion, intraoperative OCT integration with 3D digital surgical visualization is feasible, and the large screen-based visualization of the OCT data stream minimizes the need for an accessory screen utilization. Compared to conventional intraoperative OCT, digitally enabled intraoperative OCT may offer superior ergonomics and increase attention on the surgical field while reviewing those OCTs. However, additional studies are needed to better assess patient outcomes, surgeon experience, and the overall value of integrating technologies to enhance your surgical theater experience. I want to thank my colleagues at Cole Eye Institute for their help in this project, especially my mentor, Dr. Justice Sailors, as well as the rest of his lab for their help in this project. Thank you so much for your attention.